All right, so we're going to talk about web source OCT and the next frontier in imaging. I've actually been fortunate enough to have the Topcon Triton in my office for the last 3 years, actually, since 2014. And 4 years now, actually. We've had a lot of great experience with seeing the evolution of the device from a hardware standpoint, as well as from a software standpoint, as well as integration of OCT angiography. So, you know, we've seen a large evolution in OCT imaging over the years. We've gone from obviously time domain OCT to spectral domain, and now we're moving towards web source. Obviously, spectral domain has been very good. It's the mainstay of largely what we've been doing, but there are a lot of advantages that we're seeing, and we have published now with web source that I think are worthy of note, and we're going to walk through some of that today. So, massive evolution in OCT imaging over the years, of course. We've seen lots and lots of devices come on the market ever since the beginning in 1996, where the first commercially available OCT device was available. We've really moved up the plane and gone continuously towards more, faster, higher resolution products, and now we're officially in the web source space with the Topcon Triton. So spectral domain OCT, we know how this works. I mean, obviously we use a reference mirror, which gives us a reflectance of light off of the retina that is subsequently captured and provides us the images that we see. So web source OCT follows a similar format, except that in this case the reference mirror is fixed, but we have a tunable laser source. And we're moving from the 840 nanometer wavelength to the 1050 nanometer wavelength in order to see and appreciate the differences. So what are the main advantages that we're seeing from a technical standpoint in web source OCT as compared to for spectral domain? This graph here on the left basically shows us the degree of depth of penetration and sensitivity over time. So with our red curve, we can see that spectral domain OCT, as we try to penetrate much more deeply, we get a loss of sensitivity. And as we go into deeper and deeper structures, we lose information. Whereas with web source OCT, our sensitivity remains relatively high, even with a greater degree of depth of penetration. So depth of penetration is really one of the major advantages of web source OCT. So we look at this, of course, you know, a lot of great advantages. We have a higher acquisition speed now at 100,000 A scans per second. We have 1 micron resolution. We're getting greater degree of penetration. The sensitivity is better than traditional spectral domain OCT. And from a clinical standpoint, we're actually getting information a lot faster, 5 to 10 times much more faster. And of course, with the greater depth of penetration, we're getting a higher resolution of the deeper structures like the choroid and the sclera. So, you know, this is actually an image from the Heidelberg OCT, which will highlight for us, even when you have a really good spectral domain OCT device, where we start to see failure. So the zero delay line here is shown in green, and some of us probably appreciate that. As we try to get deeper and deeper penetration to the back of the eye, we're getting sensitivity roll-off, like the graph shows up in the top left. The images in the bottom here of the retina, they're less clear as a result of us trying to get a deeper penetration because the wavelength is shorter at 850 nanometers. Here's another example of that. So web source on top, spectral domain on the bottom, same patient, and we can see that as we try to get a deeper penetration with our spectral domain device, we get increased sensitivity roll-off, and we're losing information in the deeper structures. So what about patient stability, right? We're seeing higher volumes of patients in our practices, and many of them struggle with some of the lighting effects of our OCT device. You know, some of the OCT machines have a big blue light flashing in the patient's eye. It can be quite uncomfortable. One of the major advantages that we've seen with our web source device is that we're in the invisible spectrum now. So patients will sit down with the longer wavelength, and they won't even notice that an exam is taking place because they don't have a blue flash in their face taking a picture. So in our practice, we've actually been using it for, again, as mentioned, 4 years. And the patients have remarked that, is this a new machine? How come I don't experience the same uncomfortable after light effect that I used to with the other device? Oh, I'm so glad you got rid of that other device. And it's a matter of obviously the right device for the right patient, but from a comfortability standpoint, we're getting much more stability, comfort, as well as just cooperation. You know, a lot of the work that we do, we can only get images from patients that are cooperative. If you're not cooperative, the images are going to be bad no matter what device you have. So having a device that's in the invisible spectrum allows us to get even better quality images from the worst possible patients. So this is a side-by-side example of what we're seeing with in our practice of a spectral domain device versus the Topcon Triton. You know, we're going to start to touch upon OCT angiography, and just from a time standpoint, the device itself is designed very intelligently for the operator. You know, as doctors, we're not the one taking the images. The technicians and the photographers take the image. This is a side-by-side comparison of the OptiView on the left and Triton on the right. In real time, similar patient, and the amount of time that it takes to acquire an OCT angiographic image. As I said, we're trying to acquire high volumes of information now in the area of OCT and OCT-A. And we see the advantages in terms of a speed of acquisition with the web source device far greater than we do with our spectral domain device. So on the left, you see the device is still capturing and processing, and on the right side of the screen, we're done. Okay, so there's a significant delay in terms of our spectral domain devices in processing the images when we're trying to do OCT angiography. So now, obviously, we have multiple OCT-A devices that are on the market, and every vendor is offering the service. In the web source space, this is where OCT-A tends to do its best. So we're trying to capture high volumes of information, significant vascular detail. We're scrutinizing every little tributary of the vessel to determine whether it's a CNVM or a microaneurysm. And as we look at this, with the Triton, we have, speeds up to 100,000 A scans per second, and obviously are able to do all the different size of frames. But the key differences that we're seeing between spectral domain and web source are in terms of acquisition of information quickly in order to limit the artifacts that we see with this technology, which includes motion of the patient or a saccadic eye movement. So this is an example of a wide field fluorescein angiogram, which we would normally do on a patient, obviously with vascular disease, where you can see the patient has a vein occlusion with some non-perfusion, and here's the corresponding OCT angiogram. Okay, so we can appreciate that the same information is obviously being provided to us. It doesn't mean that we're obviating the need for fluorescein angiograms, but our utility for FA in our practice may start to shrink as a result of having access to a certain degree of OCT angiographic information. So how many of you have OCT-A in your practice? Anybody in the audience? One? So not many of us, right? And we're considering, where does this fit into our practice? How do we acquire the images? This is an example of a normal eye, and just showing the different layers. We can see the superficial capillary plexus in orange, the deep capillary plexus in green, and then of course the choriocapillaris in blue, and the outer retinal area should obviously be avascular. So, the way that the Triton presents the image is also very similar. You get a large 6-up view of all the different layers simultaneously, and we'll walk through some case examples of how that's helpful. So here's a normal example of a 3x3 case in a normal eye. You'll see all the different layers that are shown for you with good segmentation. And one of the things I can speak to is in our practice, we actually have the luxury of having literally every OCT from OptiView, Zeiss, Triton, Plex Elite, Angioplex. We have all the devices. And when you do a head-to-head comparison in a real-world setting, our throughput is a lot faster with our web source device of Triton, as well as the segmentation is a lot better with this device than many of the other devices. And we'll see some examples of that. So here's an example of a patient with a CNVM from wet AMD, nicely delineated here. This is no post-processing, no post-editing from my side on the segmentation. Very clear view of the CNVM that's shown up here in the outer retinal slab. And obviously down below, you have a beautiful long OCT line scan, which shows you the degree of impairment of the anatomy. So this is the on-FOS view. Again, some of these images are from the earlier generation of the software and then also into the newest generation of the software. You can see here, you have the ability to scrub through all the layers yourself and identify the CNVM as shown up there. So the bottom left corner actually is what's called a depth-decoded image. And so for those of you that are first time experiencing OCT angiograms, the depth-decoded image allows you to see which layers of the vessels by color. So in this particular case, the choriocapillaris is represented by green, and the CNVM obviously comes from the choroid, and hence it's also labeled as green. The purpose of this really is to make it a lot easier for you to appreciate the differences in the layers and where the pathology may be located. So here are some examples from Carl Glittenberg, who's around, has done a great job in putting some cases together. These are images from our real-world practices. In the bottom right corner, you can see the web source OCT image, and then on the far left, you can see these images from the OCT angiographic device that are evident of what's hiding behind that yellow subretinal fibrotic material, some of which is scar and some of which is CNVM. One of the beauties of web source is that all this information is captured so much faster than our traditional spectral domain devices that we get less artifactual influence, particularly from motion. Here's another example. This patient had type 2 CNVM, and you can see very nicely how well and how large the CNVM is and to what extent it's actually involving the rest of the retina. And there's work being done in this area right now in order to figure out do these patterns of CNVMs mean anything in terms of treatment response? And so we're in this early exploration phase of finding out, are certain CNVMs by OCT worse than others in terms of how they respond to different of the various drugs we have access to? And then I think here one final example of PCV, or polypoidal choroidal vasculopathy, and you can see obviously that there are some small polyps that are visible within the large network of vascular structure. So what are the possible applications of this? You know, as we integrate this into our practice, what we're trying to do is trying to delineate our CNVM lesions and see if we can track them over time. This is an area that's very hot within the software, and Topcon's done a nice job of getting some early data together that we're going to be integrating very shortly in order to allow us in a real-world practice to follow the shrinkage or expansion of the CNVMs in response to treatment. So you can see here, you know, the area of the lesion, for example, in this particular case is given, the area of the vessels and the vessel density. All of this is in the early pilot phase of evolving data in terms of how we get to use it, but this is ultimately where we want this technology to be in our office, is that it should provide us some objective benchmark to say, you're getting better, you're getting worse, rather than fluid, no fluid, which is kind of where we are now. So this is a study actually that was done out of Dr. Sada's practice in California. And you can see here they actually looked at this very carefully, which shows the shrinkage of the CNVM over time in response to anti-VEGF therapy at different time points. And again, as those of us that are doing treat and extend paradigms, if we're trying to tailor and customize our therapy, having software, having high volume data with high resolution is going to be key in order to apply some of these new learnings about where to tailor the patient's treatment. Maybe they need it 2 weeks earlier than what we thought they did, and maybe this is the best way to do that. This is still an evolving science, but this is ultimately where we want to take this technology. So speed. We talked about obviously speed of acquisition, the fact that we can acquire lots of data very quickly. This is on the right side of the screen is a volume rendered image of a patient with a retinal vein occlusion, and you can appreciate the macular edema or the mountain-like shape of the macular edema. And this is right out of the Triton. So we've taken the Triton data, and because we were able to capture so quickly and efficiently, we're able to package that data and give a volume rendered image. Now, obviously for presentation purposes, it looks nice. How do we use this information? Can we start calculating volume of edema instead of just area, and macular thickness concepts begin to change? You know, so as we start to explore what the information we can get out of these machines, our applications will also start to change. So I think, you know, this is the biggest and best advantage of subsource OCT right now that I could tell you about is the fact that its depth of penetration through media opacities is greater than spectral domain. So on the far right of the screen is a patient from a study we published last year looking at patients that were treated with for macular hole surgery with a vitrectomy that had gas, obviously, and that patient has 95% gas fill as post-op day 1. And you can see very clearly that the macula is visible. So because we have a long wavelength, gas is no longer an obstruction. You can image through gas, you can image through oil, you can image through blood, you can image through cataract. There's really limited media opacities that can actually impact or attenuate the signal. It's just designed to go through all of this, and we'll see some good examples. In the middle, there's a patient with a 3+ NS cataract. You probably get a good spectral domain image, but would you see the choroid? Would you see the sclera? Would you see the veins penetrating the back of the eye? You wouldn't see any of that detail. So we knew preoperatively this patient had wet AMD, and that obviously they needed to be treated before they went into surgery. On the bottom right is another case we published in ophthalmology. This is a bad diabetic with PDR and a pre-retinal hemorrhage. There's no view on this photograph of the patient's macula, and an OCT would end up being obliterated. We did a swept source OCT and very clearly could see subhyaloid hemorrhage, neovascular tissue, and the fact that the macula is actually fine. There's actually no macular edema in this case, just a lot of PDR and neovascular tissue that was bleeding. This kind of blood would have killed the machine in the previous iterations. You would not be able to get through that kind of blood. What about small pupils? So, you know, our patients get older, they're less, well, they don't dilate as well. Some of us have injection clinics, and we may or may not dilate patients. I can tell you, since we acquired the Triton, our utility for dilating patients that for injection purposes has gone down to 0. We don't need to dilate those patients. We're able to image them very efficiently because we're in the invisible spectrum. we're not stimulating the pupillary response when we're doing OCT anymore. They don't notice that this is happening, that they're getting a scan. The pupil's not reactive, and we can get through a very small 3 millimeter pupil. You can see here in the bottom right that the infrared image is garbage. We can't get it because the pupil's too small. That part makes sense. But the OCT is very clear. You see the retina, RP, choroid, sclera, nerve, everything is there through a 3 millimeter pupil. What about gas? I mentioned the word gas earlier. This is a patient of mine, another patient from that study. High myope, posterior staphyloma. You can see the gas reflex coming off the fundus photograph. Far left of the screen, obviously a very long and complicated looking eye with staphyloma changes. And very clearly, if you look up close, you can see I see sclera, bone, orbit, and I even see my gas reflex. I can't go back, unfortunately, but you can see the gas reflex meniscus right at the fovea, and the hole was still open. So, that's post-op day 1. All of us know that are operating on these patients that's the biggest morbidity with this is positioning and face down. If we can look at them post-op day 1 and change our paradigm, that will be pretty significant. If we can be confident about the hole status, which we haven't really been able to do consistently with spectral domain, that will be a big advantage. This is another example of a patient with a cataract, anterior subcapsular cataract, and you can see very clearly the retina was imaged, pretty much with no problem. So here's a nice head-to-head comparison of spectral domain versus SWAP source. So you can see here in figure B is our SWAP source Triton image through blood, and on the far right in figure C and D is through spectral domain, and that's a Heidelberg OCT, which is again we have good technology at our disposal, but sheer from the fact that there's a shorter wavelength at 840, 850. For spectral domain, you get the backscattering from the blood, whereas with SWAP source, you just cut right through it. So significant advantage on those difficult patients where you'd otherwise break out a B scan and start maybe looking at things in a different way. So vitreous obstruction. This patient obviously has like 4 or 5 plus asteroid hyalosis, and you might get an FA or get a B scan to look at the posterior segment. Very clearly, you can see the vitreous detail. You see all the retina, choroid, scleral information. Our utility in our practice for a B scan as a result of vitreous hemorrhage or vitreous obstruction has gone down to virtually 0 because we can actually get through all of that with a long wavelength SWAP source OCT. So, this is a little digression on sort of what we can do with our device. Obviously, the device has got some unique tools to it. There's an internal fixation light, external fixation light. So if you wanted to get peripheral pathology or do some wide field imaging, you could do that, and we pioneered a technique for that. So I'll show you what that looks like. We have the ability to take longer and longer line scans now. So because the device takes line scans that are 12 millimeters long versus the traditional 6 or 9 millimeters, we can actually take multiple line scans together and get a wider perspective on what's happening. So how do you use this in real world practice? Here's a patient of mine with an asteroid hyalosis, with a astrocytic hamartoma, and you can see very clearly that we can obviously get multiple detailed cuts of this particular patient's pathology. So we're not in the posterior pole, right? We're out over there in the corner, just outside the arcades, but we can navigate the patient with this device based on the way the device is set up to do internal or external fixation, and just veer them out to where we want them to look. And that's the OCT-A of that case. So you could even take OCT-A somewhat peripheral in this early stage of SWAP source. So here's another lesion that's very, very far out. Obviously, we're over here at about 100 degrees out, over outside the equator. And you can see that this capillary hemangioma is here, and we will be able to OCT that using the Triton. So again, highlighting the fact that we can get good information out into the periphery with the device that's otherwise stationary. So what about surgical cases? This is a patient with a retinal detachment that had a pneumatic retinopexy in our office. As I mentioned, gas is no longer a barrier, and we have long line scans that the device can take. So you can actually get information about how well your pneumatic is doing or your detachment patient. Is the fluid resolving? Is there a new break? Is the break covered properly? Do I need to do anything else additionally surgically? This is all, we've opened a whole new frontier on managing these surgical patients, whereas you may not get an OCT on a patient with gas because the utility was probably low at that time with spectral domain. So here we can see obviously there's subretinal fluid and the patient's still recovering, actually was reducing over time, but there was still a small leak that was happening post-pneumatic retinopexy. Another example of high myopia. These eyes are also obviously very, very difficult to image. You know, we often get image doubling in our myopes, or we don't even get a clear image because their eyes are so long. The fact that the wavelength is 10-50 nanometers, we're able to get all the way to the back and get great information about conditions like myopic foveoschisis, which obviously are very complicated. So here's that example, myopic foveoschisis, right? You know, we get such great detail of the retina and vitreous now. We can appreciate that there's actually schisis happening in the inner retinal layers as well as in the macula with obviously some subretinal fluid. And from a surgical standpoint, when I see this kind of image, it's actually helpful for me to realize how delicate do I really have to be when I'm going in here? What do I want to avoid disturbing? This tissue is very thin and friable, and obviously we can institute breaks very early. So getting a broader perspective on what we're used to seeing is something new, and at this point is helpful. Another example of a macular hole. Now, these are all done with the Triton, right? These are all images that are done in our office by taking a couple line scans and then putting it together. And this is a macular hole patient. You can see out here, there's a flap of vitreous tissue that goes out way out into the periphery. So from a surgical planning standpoint, from a disease understanding standpoint, these images are very instructive. This patient has a choroidal granuloma. You can see very nicely there in the far left of the screen the granuloma and the depth of penetration that we're getting with this device. So as we sort of wrap it up, I mean, these cases all highlight the fact that we're getting a higher sensitivity. I've described the patient stability and deeper penetration. The penetration through media opacities is really the major leap forward here. Blood, cataract, oil, gas, no longer a factor in terms of getting great anatomic information. We get information on vitreous all the way through the choroid. The acquisition speeds are very quick. You know, our technicians in our office, we have one device. They often kind of argue about who gets to use that device that day because it's such a workhorse for our practice. They can see a lot of patients very quickly. And so the applications of swept source OCT, even in the space of OCT angiography, are expanding and moving towards more biometrics that we can hopefully use to customize and tailor our anti-VEGF therapies. So this just sort of wraps it up. This shows another example of what we can do with these images. So we've taken one of our OCT-A images and volume rendered it, and we're able to actually get in-depth vascular information about the degree of impairment of blood flow in these eyes by taking that same high volume data set and putting it into a volume rendered fashion. So this just reiterates everything we talked about, but it's a nice, cool fly-through that we are just stumbling upon how to use this information. We can see blood clots in this process and cholesterol plaques, etc. All right, well, I'm hanging around, so if you guys have any questions, I appreciate your attention. Thank you.